for NYSNA, New York State Nurses Association, and has served as a mentor on the Clinical Advisory Board for Adelphi University, Heaven Full College of Nursing.
Good afternoon, everyone. On behalf of the 37,000 registered nurses and healthcare workers that I represent, I'd like to thank you for the opportunity to address you today. As many of my panelists have mentioned, comprehensive plan to address healthcare disparities is needed. So I'm going to talk to you today about safe staffing. As nurses, every day we see, can you hear me?
Yes.
As nurses, we see every day how this crisis hurts our patients. But hospital administrators are actively going against our state staffing legislation. The State Staffing for Quality Care Act, a bipartisan piece of legislation that sits on both the State Assembly and State Senate, would establish a minimum floor for what is safe for patients and nursing. Putting safe minimum staffing levels into law will take some of that power out of hospital administration's hands and put the focus back on patient care. Many hospital administrators have said that there is no link between nurse staffing minimums and patient outcomes. However, reports from the American Medical Association have confirmed that the number of patients assigned to a nurse has a direct impact on our ability to appropriately assess, monitor, care for, and safely discharge our patients. They've also argued that mandated staffing ratios could force hospitals to close, cut vital services, and force layoff of other healthcare workers. The truth is that New York hospitals have made record profits over the past few years and have spent more on hospital CEO salaries than refocusing those profits on patient care issues. In California, the only state that has adopted safe minimum staffing standards, hospital income rose dramatically after ratios were implemented, from $12.5 billion from 1994 to 2003 to more than $20.6 billion from 2004 to 2010. There was no evidence that linked changes in hospital finances to implementation of safe staffing ratios after the law was enacted. In fact, some managers reported that the staffing legislation made it easier to secure funding. However, most importantly, not one California hospital closed because of ratio implementation. On the issue of ancillary care layoffs, non-nurse staffing levels at hospitals in California actually increased after safe staffing ratios were implemented. Ancillary staff continue to be vital to the healthcare team after safe RN staffing ratios are implemented. In fact, the State Staffing for Quality Care Act actually requires hospitals to maintain appropriate level of all caregiver staff. These proposed ratios are not abstract numbers. They are based on science, evidence-based practice. Study after study demonstrates and proves that lives are saved when hospitals staff safely. Patients get better care, and nurses are able to do their job effectively. We need minimum standards in this state to ensure state patient care. This resolution supports a law that will do just that. It's not complicated. We need safe staffing ratios. Currently, in New York State, New York Health and Hospitals Corporation, we see 1.2 million patients annually. If we have the Safe Health Bill passed, this would increase to about approximately 2 million plus patients that will be seen in our public hospitals. In order for us to increase access, we also have to increase quality. You can't have one without the other. So quality care means having enough qualified licensed providers at the bedside to care for our patients, to assess their needs, to make sure that when they go back into the community, they can function. Also, in order to have a legislation that addresses everything, sometimes we can't put it in one bill or one act. So we do support the New York Health Bill, but we also want to have state staffing legislation. We don't want to wait till we get these 2 million plus patients to then figure out who's going to provide it. Safe staffing is RNs, it could be nurse practitioners, it could be midwives, as this doctor pointed out, our mortality rates and infant mortality rates. These can be prevented. This is all preventable, and we have room for improvement. And I'm asking you all to support our resolution for safe staffing. Thank you.
I want to introduce Jo Wiederhorn. She's actually going to remark from perspective of the medical school point of view. She's a long-time historic career in public health. She's held positions of Chief of Staff to the President and Associate Executive Director of MetroPlus, Health and Hospitals, Medicaid Managed Care Plan. I'm getting used to saying Health and Hospitals. I'm getting used to saying HAC for so long. Ms. Whedon was then recruited to NYU School of Medicine, where she served as the Chief of Staff to the Dean. While working there, she started the school's Institute for Urban and Global Health. She studied the link between urban health problems and the global health conditions. In 2002, Ms. Whedon became the president and CEO of the Associate Medical Schools of New York and the New York State Academic Dental Centers. Joe?
Thank you, and thank you for the opportunity. You know, I'm really pleased to be here, and I want to talk about, you know, what it is that's happening in this state in terms of a physician workforce and a diverse physician workforce, because access is very important. The ability to get to see a physician is very important, and the ability to not have to worry about how you're going to pay for it is very important. But ultimately, what it comes down to is, are there physicians for people to see? Will people go see physicians who aren't of the same cultural or ethnic background as themselves? And there have been many, many studies that have shown that it is more likely that somebody will go and see a physician who understands them, understands their culture, understands their ethnicity, can speak their language. When I worked at Bellevue, there were 85 different languages that were spoken that people came through the emergency room. How many of the physicians who saw them could speak to these patients without an interpreter in the room? I'll give you another example. Through one of our programs, which I'll talk about in just a minute, we had a young man who really wanted to go to medical school. Absolutely, it was his life dream. He came to this country from Colombia when he was 19 years old. Couldn't speak any English whatsoever. He put himself through Mercy College, applied to medical school, initially was rejected by the medical schools, but one of them said, one of the schools in the state said, we have a program here that can help you and will guarantee you admission into medical school. He accepted that offer. He made it successfully through the program. He is now the director of neurosurgery at New York Hospital, Queens. 80% of his patients do not speak English, all right? So we need a physician workforce that is going to look like the population of this state, particularly if we open up access to everyone in the state. Currently, there are 35% of New York State's population are non-white. Currently, 9% of New York's physicians are non-white. We need to do something about that. So let me just give you a little bit of history about what the medical schools have been doing up until this point. We now run 4 programs called post-baccalaureate programs. These are programs that come, after you finish college. They're unique in the country in that the student, to get into the program, has to apply to medical school. The medical school refers them to one of these 4 programs. And if they successfully complete the program, they are guaranteed entry into the medical school that referred them. We've been running these programs since 1991. We started one in 1991 at the University of Buffalo. In 2008, we started 3 more. Those programs also provide master's degrees, so that when the students finish those programs, they have masters, and then they go to medical school, and they come out with MD, MS degrees. These are students, and I need to be really, clear about this. If you're referred to one of these programs, and let's say, most people, they don't apply to just one medical school. They apply to 15, 20 medical schools. But if you apply to one of the medical schools in New York State and you are referred to one of these programs, if you get accepted at any other medical school in the country, you cannot attend this program. The intent of the program is to increase the pipeline, increase the number of diverse physicians within the state, all right? The intent is to ensure that we have students and we have physicians in this state that accurately represent the population of the state. So since 1991, in our Buffalo program, we've had 408 students who otherwise would not have made it through medical school enter medical school, successfully complete medical school and their residencies, and are now practicing physicians. Over half of those are working in primary care. But as I mentioned with Dr. Nito, he's a neurosurgeon. We need neurosurgeons as well. We do need primary care physicians. I'm not saying that we don't. But we need neurosurgeons, we need psychiatrists, we need OBGYN, we need specialties of every kind. And we need physicians of every race and ethnicity to treat people in this state. So why am I up here besides just telling you about what a great job we're doing? I'm up here because we have another problem in this state. Dr. Moore talked about how he gets paid very little for the patients that he sees. Students leave medical school now with a median debt of $183,000.
No.
That's medical school. Now, you know, the government has seen fit that, okay, you don't have to start paying this back until you're done with your residency, which is actually at least 3 years. And for Dr. Nieto, it was 7 years after medical school before he could start to practice. He doesn't have to pay his debt back, but the debt accrues interest. So you're looking at people with $250,000, $300,000 worth of debt. How can somebody with that kind of debt go and work in inner city, New York City, Buffalo, Rochester, Syracuse, be a primary care physician, and be able to pay back their debt? It's impossible. So why I'm here today is to talk to all of you about a program that we are trying to get support in the Senate and the legislature and the Assembly for, which is a scholarship program. What we want to do is we want to take SUNY medical school tuition, which is currently about $40,000 a year, and provide students who have successfully completed one of our other programs. So these are students who have successfully completed, the state has already supported them going through a post-bac program. They're now in medical school. So what we want is the state to say, okay, we're going to support you and help relieve some of your debt. We want the state to say, we will give you another $40,000 a year, total of $160,000, to help so that you don't have to have these huge debt loads when you're done with school. All right. This is not money for free now. In return, the students have to make a commitment to work in an underserved area. So they will have an obligation to go back into a community that is underserved and work there. For every year that they get a scholarship, they will have to spend at least a year working in an underserved area. So I'm here to ask all of you to support the idea of open access, whether it's through no insurance or single payer insurance, or whether it's through supporting our nurses or our physicians, and to really help us make healthcare accessible for everyone in the state. Thank you.
We're going to go into Q&A, but first, I just want to say that all our panelists did a great job, right? And we could spend hours talking about health disparities. There's whole conferences that go around it. What we haven't really addressed is inequities that continue those disparities in a real conscious and confirmed way of looking at it. And, you know, there's plenty of inequities that we can speak of. There's inequities in who decides when a hospital will close, when they will merge, without the input of the workforce and the community, and we've seen that for too long. We can have the inequity of unfairness in terms of the distribution of dollars that's supposed to go to our true safety net, while other hospitals gain from it. That's an inequity. We can talk about the conditions in our community that continues keeping us sick. Some people call it social determinants of health. But you know, we have a whole bunch of terms in policy, but the reality is the conditions that are impacting the well-being of our community. we can discuss as well the issue of not having enough resources for pipelines that can help our young people, particularly people of color, get into the health professions, become doctors and so on. All this is something that we all have to be charged to looking at too. And it's very important. One thing we could do is, right now, and there'll be some things, is to push for the single payer bill. We have a large coalition, but we can be much larger. Particularly, we would like to ensure that upstate we have a lot more partners. And then downstate we solidify and strengthen ourselves to pass this bill. While we're doing all the other issues that we're trying to pass in other legislation. I want to get a little privilege to mention someone that I believe knows a lot about health disparities, works well. Yvonne Graham, who's the director of the Office of Minority Health and Health Disparity Prevention. I know she's always been with us on these issues. So I want to open it up for Q&A. So any questions or comments? Let me just start from the back and roll down. Sir? And can you say your name and where you're from?
Yes, my name is Perry Frank. I'm a cardiologist, and I applaud what you people are doing. I'm a cardiologist. We go to neighborhoods where there's health disparities. I was born in Brooklyn in a poor neighborhood. We go to Brooklyn. We go to South Bronx. We partner with Soho, HCCI, and everything like that. Why should somebody in Brooklyn, as the health profiles just said, live to the age of 74? If you're in East New York, where I started, and why should somebody in the South Bronx live to 75? And if you live in the financial district, which is mostly white and Asian, you live to 85. So I think we have to do things like you're doing. We love going to areas where people have no health care and bring the same type of health care that they have, that I'm privileged to have on Long Island. So these are the kind of things you have to do. Why should an African American or Caribbean American have 3 times the death rate from hypertension? Why should the stroke rate be double? Why should Latinos have strokes 13, 14 years earlier? You're talking about healthcare inequalities in America. So we have to work together to try to make change the disparities in healthcare. And we go to every single area where we think there's healthcare and disparities, and we set up mini hospitals. So we'd like to work with people like you and make a difference, so you don't have 11 years difference in lifespan if you live in Brooklyn than if you live in Long Island.
Right.
Thank you.
Actually, you.
Yeah, I just had just a really quick question. So I was just wondering for either Bill Jenkins or anyone, how you would kind of go to Big Pharma and get them to lower the price of any type of drug, because everything's institutionalized. You know, Big Pharma is all about making money. So maybe it's just that I don't understand how you get such a big, like, corporation or institution to kind of lower their prices that are, like, they have patents on everything. So are you going to do something like Brazil or in India where they're kind of taking the drug in?
Anyone want?
I think that in this country the key answer would be bargaining power. And today every health plan bargains with drug companies. They bargain on behalf of their own number of enrollees, and so they say to the drug company, if you give us a discount, we will guarantee that we will cover your drug and not the drug sold by your competitor. And of course the consequence of that is that the customers of that insurance company, if their doctor thinks you need drug number 2, not drug number 1, your health plan may not cover that drug, or may charge you, 40, 50, whatever, a lot of money for going off the company's formulary, and that's what pressures you to stick with the drug where they negotiated a price with the drug company. Under the New York Health Act, First of all, the state would be negotiating on behalf of 20 million customers and would have the ability to encourage drug companies to pay us discounts because we would put their product on a preferred drug list. But under the New York Health Act, if the drug isn't on the preferred list, that doesn't mean the consumer doesn't get that drug. It doesn't mean that the consumer has to pay a big co-payment, because we don't have that in the New York Health Act. What would happen is your doctor calls up the preferred drug program that would be run by the state and basically makes the case for why you as patient ought to get that drug. And under the New York Health Act bill, even if the state bureaucrats disagree with your doctor gets to win. Now you might say, is that enough of a process to encourage doctors to prescribe the drugs from the companies that paid the state a big discount? And the answer is, fortunately, we have experience with that, and we know that the answer is yes. Because for several years, that preferred drug program is what the Medicaid program used. They now have switched, against my advice, to where each Medicaid managed care plan does their own bargaining with drug companies, and they have the whole formulary business. When the preferred drug program was in full swing, 99% of the prescriptions that were written under Medicaid were for drugs on the preferred drug list. It worked. And why did it work? It worked because doctors had confidence that part of what made up that list was drugs that were scientifically evidence shown to be the best drug in a given class. Secondly, the process of having to call up and get approval, even though you could ultimately get approval, was enough of a speed bump that doctors figured, I'll stick with the preferred drug list, unless they really felt strongly. And finally, because of all of that, drug companies were willing to pay the state hefty rebates or discounts to get their drugs on the preferred list. So nobody had to walk away without their drugs. Nobody had to pay huge co-pays in order to get their drugs. The state paid a lot less money, and doctors and patients were a lot happier.
So, Dick is a hero. He has championed this policy for many, many years, and like a lone wolf, so to speak, in terms of the kind of respect that he has grown, that he has received, and has grown for this type of legislation, and but it's a political process that we're in. It's not simply a process of the way whether something is good or bad. There are forces that are gaining a lot of resources from your pockets in this dysfunctional system. And in the meantime, there are others of us, our neighbors and friends and family, that are suffering bad health care. Okay? So, we are in an election season.
Thank you.
There is going to be somebody that's going to be a president of this nation that will have the opportunity to decide what is the best health care policy for you and your family. You might want to pay attention to that. Now, this is not a campaign speech. I'm just telling you, policy and politics are part of the same meal. You can't have one without the other. And if you have bad politics, you have bad policy. What are we suffering from? Bad policy in terms of our health care for our families. Find somebody that's, I'm not telling you who, but pay attention to who's going to be your next president. Because that person might have something to do with your health.
Right.
So, Maura?
Yeah. I want to bring it back to the disparities and the inequities, and one of the things that Anthony mentioned was that inequities can also be caused by inequities in funding. I'm Moira Dolan. I represent workers in the public hospitals through DC 37. Is HHC in the house back there? We have in the health and hospital system, yes, there are problems with the insurance payments, as has been described here by the legislators. But we do have the public hospital system where we do see everyone. We see 1.2 million patients, 450,000 are uninsured. And we are mainly seeing the people who are suffering the most from the healthcare disparities. And we're not getting paid for it because of the problems that they've described. And the governor is trying to take even more resources from us. Right. Fortunately, Senator Perkins and Assemblymember Gottfried have legislation that they have already co-sponsored to reverse that and to create an enhanced safety net rate that would provide more funding for public hospitals and safety net hospitals. So we have to be very aware of all of our politicians from the federal level, the state level, the local level, who are affecting these decisions about funding. Thank you very much.
We're going to start this way. Question from,
Yes, good
and I
morning.
see you in the back.
Good afternoon. My name is Earthly Jules, and I'm a parent of 4 children, and I want to go into the co-payment thought because yearly you have to pay $25 to $50 per kid for a physical, as opposed to any emergency room you have to go to. You have to pay, but you're already paying for the insurance itself. So when I'm asking the question is, when you have multiple of children, that co-payment is a bigger expense on our family, as well as the expensive health care we already paying. So I want to know, can we put that on the agenda to find out those co-payments?